Well, hello everybody, and thanks very much for inviting me today, Martin and the team. I'm delighted to be here and delighted to be here with Des and Paul. I had planned to bring Paul in just maybe to say a few words on behalf of Wexford County Council, but if he's coming on, I'll maybe bring him in at the end. So just conscious of time and to not hold anybody else back, what I'm going to do is give you a little overview of the Wexford Living Lab. But I'll also want to emphasise a little bit about the programme. And I suppose speaking to the agenda on collaboration and cooperation, for me, and many moons ago, I worked in the sector of telehealth and telecare and the provision of assistive technologies. And it goes back even to Fernando's point at the beginning there about the support of libraries and the digital supports. And I think, Fernando, they have significant impact on health. They may not be a health-related support, but they have significant impact on health. And I can tell you a little bit more about that later. So, are those slides moving, Ross? Can I just check?
They don't, yeah, they did for a second there. Yeah, excellent.
Okay, so very briefly, just a little bit of background about Age Friendly Ireland. Age Friendly Ireland are a shared service. We're hosted in the local government sector. A shared service, I suppose, is a factor of the 2014 Government of Ireland Reform Programme. And basically, it means that the local government service or a lead local authority will adopt a programme on behalf of all 31 local authorities across the country. And Age Friendly Ireland had started, as you'll see on the left of the screen, around 2009 as a national programme to support the development of an age-friendly programme and strategy in each of the local authority areas. And it went through a number of iterations and then proceeded to become a shared service in 2017 when we had full extension and rollout. I suppose one caveat we always say is we're hosted and supported by the local authority in terms of resources and heavily resourced by local authorities with some governmental funding to host the shared service. But we're very much anchored in everybody's agenda. We're a multi-sectoral approach. We engage with all aspects and all sectors. And I suppose all of our programmes are based on that and that commitment to collaboration. So just very briefly on the left, you'll see the World Health Organization they did a global study in 2006-2007, which produced the Age-Friendly Cities and Communities Framework. And within the context of that framework, they identified 8 themes, which would be what thematic areas we needed to pay attention to in order to plan for demographic change and population ageing. And I suppose, as you know, there is going to be a significant shift in the rate of ageing. The mortality rates have increased significantly. And also we're going to have quadruple the population of those over 80. Which is going to have impact. It's a huge amount of opportunity, but it's also going to have challenges which we need to respond to. And we always think of those in a very positive context. So just to let you know, the first age-friendly programme started around 2008 with the first strategy formally launched in 2009. And then if you see at the top, what we did was we then devised a methodology. And that methodology included a structure, which I'll take you on to the next slide. And we carried that out across each of the 31 local authority areas. We had the historic Dublin Declaration, signing a declaration agreed between Dublin City Council and the Age Friendly Ireland Programme, the World Health Organization and the International Federation on Ageing. And in 2011, we had 44 mayors from across the world sign that in Dublin on behalf of 60 million people across the globe. So as I say, at the end of 2017, we formally moved into the shared service, which means that we're now that part of local government, but a collaborative body across all, and that was our transition. So just in terms of our structure and where we are, that's just to give you a little flavour of what we do and who we are. So at local level in each of the 31 areas, we have a strategic alliance, which is chaired by the Chief Executive of the local authority. And that's made up of a range of stakeholders, the HSE, transport provider, An Garda Síochána, president of the university, education and training boards, and then I suppose the voluntary community and voluntary sector. Local authorities provide over 100 services. So that was when the WHO made a recommendation about where programmes would be anchored. It was because in recognition of the fact that they do so many supports over transportation, roads, infrastructure, housing, community supports, economic development, that they would lead out, but as I say, involve everybody in the delivery. So we have an age-friendly alliance, which is underpinned by an older people's council. We have 31 older people's councils, which are diverse representation of the authentic voice of older people. We have 31 programme managers, age-friendly programme managers, that coordinate the efforts, produce the strategy, do the consultation and implement the actions. And we also have 31 age-friendly housing specialists. At national level, we're supported by the Department of Housing, Department of Health, Department of Rural and Community Development, Department of Transport, and our national advisory group has senior representation, I suppose, where our governance is anchored. And then within that context, we have the shared service, and we have principal advisors on housing and age-friendly business. And we have a number of national structures like the chairs of the alliances who meet collectively to look at, I suppose, the key objectives of the programme and to make sure that we're keeping our objectives as we move along. So at local level, the programme manager normally listens to the voice of older people through the strategy, and then the strategy is implementation. So over the last 10 years, we have consulted probably with about 25,000 older people from a range of different backgrounds. And what older people do, what was really unique about what we do, is we involve older people in the decision-making process. So we try to make sure that the user is there to sort of say, this is the impact, but come up with innovative solutions. And then those strategies, I suppose, are delivered at local level using, different ranges of budgets, and I suppose budgets that are statutory and that are there and delivered in an age-friendly way. What we do is from time to time, when we review the local actions, we look at scalability, and it's one of our core objectives. If something works and it works well and it's a good use of resources and it proves to be cost effective or have a significant impact on older people, we will work with the national providers to see can it have a national scale up. Speaking to Martin's point at the beginning about broad rollout. So for the Wexford Living Lab, Paul, my colleague in Wexford, said there was an interest in looking at a telehealth programme in Wexford that would have potential to have scalability. And we're delighted to be collaborating with Martin. So an overview of the partners and those that are funding it. My colleague Des here from the Integrated Care Programme in the HSE, Wexford County Council, ourselves, Tunstall Emergency Response, who I'm sure you may have heard of, the Waterford Institute of Technology, and I suppose if we move in here to our local stakeholders, the local stakeholders are critical, I suppose, in terms of how we actually implement the pilot. So if you look at the range there, we have older people's services, social care and the HSE and key people from that, the consultant geriatrician who is acute based but also has a community presence, and then local GPs as well. I suppose the clinical nurse specialist is going to be critical in terms of referrals. We also have the Get Up, Get Dressed, Get Moving programme, and as I say, Waterford Institute of Technology are contributing by way of the evaluation. So this is just an overview of what we're going to do, and when we initiate it, at the minute we have the study designed, and we have the programme rollout, and it's going to be over 12 weeks. And once we get ethical approval, we'll be at our initiate, and we'd hope that the evaluation would be ready in Q1 of 2021. So we're looking at 50 participants. We're looking at monitoring 3 chronic conditions. Now, people may have comorbidities or trimorbidities, but if they have COPD, congestive heart failure, or diabetes, they will meet the criteria. The referrals will be largely from the consultant geriatrician and the local GPs. As I said, we're looking at a 12-week monitoring period, and then the academic evaluation, the production and the dissemination of the results, and then which would include a cost-benefit analysis. So I suppose there are the key components of it. When the referral comes in, an assessment will be done, the parameters will be set according to, I suppose, the activities of daily living and the standard parameters based on what the geriatrician or the local GP will say. And then there'll be technical triage, clinical triage, and obviously the escalation in accordance with the pathway that has been set. And then we will review the impact and look at the metrics and look at cost and quality. It's important, I think, when you're doing an evaluation of a new, I suppose, assistive technology, and telehealth is certainly not new. It is evolving. but it's a new concept to some of us, but it's certainly a new concept to older people. And there's all sorts of things that you need to take into consideration when you're talking to older people. You've learned through consultation in terms of change and the way in which healthcare and trust in a system. So it's really important that our evaluation concentrates on the older person's experience and the lived experience. And we'd be hoping as well within that context to incorporate a Fitbit. And then through COVID, Age Friendly Ireland has supported a huge amount of digital transformation. And I mean, I'm talking about the basics of older people learning how to use a smartphone, how to get on a Zoom call, how to do a Skype call, how to send an email. And those are really, really important in terms of adaptability, because if we design the service but don't put the user at the centre of it, I don't think it'll have any impact whatsoever. So just in terms of our partner who's providing it, Emergency Response are based in Wexford. They're one of the largest providers of telecare in the country. Tunstall are a multinational, obviously, and they have actually a 24-hour monitoring centre in Wexford. And largely this, I suppose, the telehealth and the connected health setting will be done in a community and a clinical setting. So it's looking at how telehealth can incorporate the home, the acute setting and the community setting, and how we can efficiently use the resources. So if we have got an example where somebody is getting their data and their vital signs collected on a daily basis, and that's producing a track and trend report which somebody can remotely go in and look at, it's going to be much more cost effective, notwithstanding the fact that older people still want to visit and have human contact. But I think that what we've learned through over the years is a huge amount of missed hospital appointments, and particularly consultants appointments, because of maybe a lack of transport or because somebody was too poorly on the day. And there's a huge opportunity for technology interventions to support older people being able to maintain their health. That's just a little bit of an overview. So it's a tablet form and it's a patient app. And so I suppose the parameters will be set by the clinician, but the different peripherals that will be used will be entered. I suppose the readings and the parameters will be set manually, but then they will take the pulse oximeter or the blood pressure or the weight, and they will be taking those readings themselves at home. Now, I'll take you through in a few minutes to show you from start to finish how that's done, but older people will be shown how to use them. And they're obviously, I suppose, in terms of criteria, we don't want to be exclusive, but you want to make sure that people have some basic maybe use or understanding of using maybe a smart device. And if not, I think it'll be interesting to see how that transition works. The messages obviously will be sent to the Triagemanager in the monitoring centre, and then the intervention will occur. So that's the managed service. So the Triagemanager will provide the remote monitoring, and it will obviously be a traffic light system that will come through. So given that greens are okay and that everything is fine and the vitals are within the parameters, there's also some dynamic branching questions, you know, so that if you ask a question, how do you sleep, or whatever the case may be, there's almost like an internal triage done within the manager system. And then with Amber Alerts, they tend to be more technical. You'll have heard the cat jumped on the scales, or whatever the case may be, and the technical triage will generally ring out and ask for another reading to be taken, or make sure there's no low battery or something needs to be calibrated. And then when it's a red, that's where the clinical intervention is required. So that's where you would have your nurse actually ring out to the client and check how they're feeling, and then look at their, I suppose, readings and how they've improved or disapproved, or if somebody has gained weight or whatever the case may be. And they can decide then whether that's an escalation. So potentially, as you probably already know, telehealth has the capacity to reduce unnecessary escalations or presentations at A&E if there's reassurance that something is normal. It can also support people to go to A&E when it's critical. It can also support people to empower them to manage their condition, particularly if you have somebody with diabetes and it's an early intervention. They've got the opportunity then to really learn and look at things. If they're looking at their readings every day and they're more acutely aware of the impact that it's having on their vitals, it can change patient behaviour. So in terms of the triage manager, as we say, there's trends and there's summary reports, and these can, the clinician can be given access to these, obviously, so that they can go in remotely and look at somebody's track and trend on a weekly basis to make sure that everything is okay with the patients. And as we say, it has the capacity then to incorporate a tailored monitoring plan, so that it means that the care pathway is specific to that individual and not standardised. So this is just, I suppose, the managed service. And I suppose this is speaking to Des. I'll maybe ask Des or Paul, do they want to say anything at the end? Integrated care is the vision that we all have in terms of the provision of supports to older people. If you look at the housing options for our ageing population policy and the Sláintecare objectives to shift left, and even the programme for government in terms of an age-friendly Ireland, the vision of care is that you put the person at the centre, and that I suppose that the money will follow the patient and follow the person and is not categorised into silos. And what does that mean? And they're the supports. If a person wants to stay in their own home or their own community, they need appropriate housing, they need adaptations or right-sizing support, and their locality and their public realm and supports need to be accessible to them. And that includes things like transports and age-friendly parking and age-friendly bus stops. Then if you look at the clinical care, access to your acute care and community and primary based care, good access to GP, and obviously all your supports like physiotherapy, but chronic disease management is critical to that, and early intervention. In terms of social supports, there's a huge amount of information and communication support services through libraries, physical activity programs, social supports, befriending, meals on wheels, all these different things, shops and outings for older people, and ways in which they can integrate themselves into the community so that their overall health is impacted by that. And then the technological supports, obviously telecare and telehealth and smart technologies, robotics, domotics, basic good broadband, but also the person's digital capacity. All these are, I suppose, essential and critical to ensure that not just our current population, but our future generations have the capacity to be minded at home or stay in their own home. So just in terms of the managed service, what we're doing with this pilot is that we believe that, I suppose, the end-to-end solution from the referral right through to the installation of the tablet, giving obviously the patient, the person that's referred, the capacity to be able to use the peripherals and the tablet, ensuring that they have the connectivity, that they can use the MyMobile app, and that I suppose the equipment then is maintained, and that's where the technical triage comes in, and if there is any issues with it, that they get another visit. At the end of the 12 weeks, then the equipment deinstallation and going out and making sure that it's taken from the person and that they're, aware that it's the end of their program. And obviously with telehealth, as you know, it's a finite time scale on it. It's an intervention that can support somebody. And there's also a review to see if the person needs a further extension on that. And I'm talking, I suppose, in the long term with the long-term implementation of telehealth. And there's obviously patient training included in that and maintenance, and the technical triage and the remote help desk support. And that's really important. And we find with any supports that we've given to older people or any projects that there has to be a help desk, that if they have any queries outside that, not just necessarily getting through to the technical triage, if they have any questions about the pilot that they're being a part of, it's important that we provide that help and support. So I suppose I don't want to go over time, Ross, and that's what I wanted to give an overview as succinctly as I could. I just wonder, is it possible maybe to ask Paul or Des if they'd like to come in to add a few words?
Yeah, I might jump in from a Wexford County Council perspective. We're delighted to be supporting this project. It ticks all the boxes in terms of the age-friendly strategy. We're a county that's looking at 20% increase in over 65s over 6 years between 2006 to 2012, 12 to 18. And I don't see that decreasing, it's going to increase. So we're delighted to be able to support this project in terms of, of supporting our ageing community, allowing them to live in the home for longer. Catherine's touched all the topics there, the scalability of it, the collaboration with the HSE and others, the linkage between, this project and the local economic and community plan to promote well-being and quality of life within Wexford County Council. And we don't see it to be a once-off project either. I suppose for us, we see it to be the start of, a medium to longer term stratagem in terms of the piece. So we're delighted to be able to support and offer assistance in terms of money and staff resources and the likes thereof. And we really hope that the project goes well and that there's a follow-up to it.
Thank you, Paul.
I'll just very quickly, Ross, because I know you're very tight on time, just from the perspective of the integrated care programme for both people. One of the key tenets for us is really co-production and using the voice of the older person. And so the structures within Age Friendly Ireland really gave us that, and they gave us that reach to go out and contact or be in touch with older people right across the country. So that's really important. And the second thing I'd really like to stress is that the development of integrated care is not just about how we ensure that our hospitals and our community health services are intertwined, or that there's smooth transition for patients between community services and acute services. It's also about that wider health economy. So what's going on in the person's own locality in terms of the non-governmental sector, in terms of the local authority, in terms of the private sector. And this project, this technology project, has really, I suppose, brought home for us, I suppose, that opportunity to come with multiple stakeholders. And if you're talking about that shift left, bringing care closer to home, you cannot get closer to the person's own home than actually in the home by using technology. And technology allows us to do that. So we're delighted to be a part of it, and we look forward to seeing how things unfold over the next 3 or 4 months.
Great. Okay. Well, thank you very much, Paul and Catherine. I think you really are, a brilliant example of what a living lab is about. I suspect when you go to take the technology out of the home, people will say no. So I think the opportunity is to figure out how we might move from that original proof of concept and pilot